Very good morning to all of you. Today I'll be sharing my experience with glued IOL technique of PC IOL fixation. This is a glued IOL technique where fibrin glue-assisted sutureless PC IOL will be fixed when there is no capsular support. The indications are subluxated and dislocated cataracts for IOLs, zonulopathies, and secondary IOL implantation in case of aphakia. Here you can see a patient who came with trauma. The lens was subluxated, some vitreous was there in the AC, and there was traumatic mydriasis. The visual acuity dropped down to 660, and the IOP was 26 millimeter of mercury. So this is the surgical technique of glued IOL fixation. First, we measure the white to white, which should be about 11 millimeters. After measuring the white to white, we will do a peritomy on both the sides. After some peritomy, we'll address with some wet cautery to reduce the bleeding. And now we'll take a special type of forceps to measure around to get two scleral flaps. We can see that here we have measured out that where the flaps should be created. Just like we do in trabeculectomy, we'll make two scleral flaps of half thickness over here. Once the scleral flap is made, we'll do the similar thing on the other side also. And we should make sure that the scleral flaps reaches up to the limbus. Now asymmetry is placed and a vitrectomy is done. As you can see, this is an aphakic eye. Now 1 millimeter from the limbus, we will do sclerotomy on either side. Now we are doing a sclerotomy and make sure we'll go behind the iris. We do not do iris capture on either side. Now our microforceps is inserted into through the sclerotomy, and we are using a 3-piece IOL. Once with the left hand, my microforceps is ready to grab the haptic of the IOL. Slowly and gently we are inserting the IOL. We should be careful that only the haptic is out. Once I grab onto the haptic, I should let the optic float inside the AC, making sure that the trailing haptic is outside. Gently I pull out the haptic. I'm fixing a silicone tube or rubber tube so that it does not go back inside. The same thing will be done on the other side. This is the handshake method, where one microforceps is used and is transferred to the another microforceps. Similarly here, we go through the sclerotomy and then we pull the other haptic out. Now the interesting part of this technique is that we will be creating a tunnel. It's called the chariot tunnel, and we will tuck the haptic inside the tunnel. This will give fixation and stability to the IOL. Now I've tucked the haptic inside. Similarly, we'll be doing the same thing here. And the name, as it suggests, is glued IOL, so we will use fibrinogen thrombin glue, 1 drop, and of fibrinogen, 1 drop of thrombin, and we'll close it up. What we have seen here is that we get a stable IOL with visual outcome, no IOL tilting due to tucking of the haptic in the scleral tunnel, less phacogenesis, no uveitis glaucoma hyphema syndrome, as there is no chance for the IOL to move, and there are no suture related complications like suture breakage or IOL drop or dislocation. Post-operative 1 month, you can see the lens is well centered and the vision has come to 6.9 and the IOP has reduced to 12 millimeter of mercury. Thank you. And thank you, Bangladesh Young Ophthalmologists Society, for giving me this platform.
Thank you, Dr. Partho, for your nice video.